And we're going to talk a little bit today about DHODH, or Dihydroorotate Dehydrogenase. And I'm David Sykes, and I've been here for 12 years at the Mass General Hospital. This work has been done over the last 6 years in Dr. David Scadden's lab in the Center for Regenerative Medicine. So one of the things, of course, that we always hope for is that maybe there's an old drug out there that still has some new uses. And so this was Brequinar, and I'll come right to the punchline. We're going to talk about Brequinar, and I'll tell you a little bit about how we got there. But clearly an off-patent medication now, originally patented in 1985 by DuPont, and as an anti-tumor drug. And it was an anti-proliferative agent and a cytotoxic agent felt to be at that time. And Brequinar has been in a lot of people. We've got phase 1 trials, 250 patients with all advanced solid tumor malignancies, well tolerated, but turns out that very, very little efficacy in those trials. And then 5 phase 2 trials with almost 200 patients, again with solid tumors. And I think 2 things we'll talk about. 1, it was never assayed in heme malignancies. And 2, I think knowing a little bit more about the PK and PD, we think maybe we could do it better. But Brequinar has been in a lot of people now more than 20 years ago. When I started in David Scadden's lab, I thought, we've got this amazing sort of model here with retinoic acid therapy in acute promyelocytic leukemia. And we'll take a little look at that. But we wanted to make differentiation therapy. Forget about cytotoxic chemotherapy, where we just want to non-specifically poison the cancer before poisoning the patient. Here we want to just use differentiation therapy to trick these cells into maturing. We'll talk just a little bit about a new cell line model that we generated. We then developed a high-throughput screen, which was a phenotypic screen, came up with this molecule, and then eventually landed upon Brequinar, again, this old 20-year-old compound. We've just heard about this. Acute myeloid leukemia is still a problem. And I think right at the end of Rich's talk, they said, well, when was that standard of care, cytarabine and daunorubicin, when was that first standard of care? It was 1973, so 43 years ago. We still get the same. So it's a little embarrassing to sit with a patient who says, well, what's new? They're like, no problem, we're going to give you a drug that's 43 years old. That's the best. And thankfully, Rich has come up with midostaurin, but that's the only advance we've had in non-APL acute myeloid leukemia. And this is what's sort of really dismal, is that usually the curves we talk about are these curves. These are the patients that make it onto the trial that are all less than 65. But I think the real crazy part are these patients that can't tolerate or can't be transplanted, and patients that are 70 or 75 really have a dismal prognosis. So one quick thing is like normal differentiation, and then why are we worried, or why do we think that differentiation therapy should even work? And so one thing I'd like to start with, and I did this with the sort of medical residents, is just the concept of hematopoiesis. And so when you go to get your blood drawn, and this is actually my blood counts from 5 years ago, but the doctor says, oh, your blood count's 5.8. You're great, you'll be fine. Well, that means that you've got 5,800 cells in every microliter of blood. And if you work down the math, you end up with 29 billion white blood cells just floating around your bloodstream, right? That's not even in the tissue, that's just circulating. But what's kind of crazy is that when you think about how short-lived those cells are, and if they have even a maximum lifespan of 2 days, those neutrophils, you're making 150,000 new white blood cells every second. And so that's why we have all those Skittles out there, just to fuel the white blood cell production. So you're making a ton of white blood cells every second, right? So sometimes people say, well, cancer is just really quickly dividing. That's why you get in trouble. Well, that's not the case. Your blood cells divide like crazy. But you're depending on this nice progression from stem cell to mature apoptotic neutrophil, 150,000 times a second, to basically replete the dying cells with live cells. But you can imagine if you just end up with a roadblock, a mutation that somehow freezes that ability to progress down that normal pathway 150,000 times a second, well, that could be a problem. And leukemia, just this massive influx of immature cells that can't mature, filling up the bone marrow and crowding out the normal cells, you can imagine that gets you into trouble. My friend Peter, the cardiologist, he says these are just like teenagers at the mall. If they just grow up, they wouldn't cause any problems, right? But they're just stuck at the mall, loitering about, causing problems. So differentiation therapy is the idea that instead of killing these cells, let's just get rid of this maturational roadblock and let them go down the normal apoptotic pathway. And of course, we have a very nice paradigm for this, because acute promyelocytic leukemia, which used to be the worst leukemia to get, is now the one you want to get. And what's remarkable is that, and this is again actually before my time, so people like Rich would talk about these cases and people that would come in and would just have no hope of survival. Now, with a combination of retinoic acid and arsenic trioxide dropping chemotherapy, these patients actually do the best, right? 90% survival. Really remarkable. All differentiation therapy, no chemotherapy involved. And this is great. This is what I love from Wikipedia, right? Retinoic acid is a drug commonly used to treat acne. It is also used to treat acute promyelocytic leukemia, right? So that's what you want, right? Strong or safe enough for acne and strong enough for leukemia. So that's, of course, maybe more than we could ask for, but that's what we'd love to get. So here's the clinical problem, right? You walk in the door, you're hoping to get acute promyelocytic leukemia, but 9 out of 10, you have, unfortunately, regular AML. And just like Rich talked about, your overall survival, all comers, 25 to 30%, even more dismal in the older patients. This is just a ubiquitous slide that every AML talk has to have. That's what Ben Ebert always says, Susanna's boss. But basically, AML is not one disease, it's many diseases. And so why should differentiation therapy work? Well, we hoped, and of course this has been recognized for many years, that this differentiation arrest is a hallmark of pretty well all leukemia. And interestingly, we used, and this is probably not relevant to this talk, but we used a model system where we froze cells at a maturational block caused by HOXA9, because this was also very common. But in retrospect, DHODH and HOXA9 are not related, so I don't want to confuse anybody with that. And this was a very simple screening system. Normal bone marrow from a mouse, frozen by this HOXA9 retroviral construct. So just one change keeps the cells immature. The cells grow like gangbusters and stem cell factor. And you can then have hundreds of billions of cells, enough cells you need for a high-throughput screen. And the screen was based on basically a very colorimetric screen, because these were derived from a transgenic mouse where neutrophils became green fluorescent. So a nice 2-log switch in green fluorescence. And then they had a normal other markers of CD11b, another cell surface marker of myeloid development. And so our screen really asked a very simple question. Could you take an undifferentiated cell, GFP negative, MAC1 negative, and look for any compound, didn't matter what it was, any compound that could cause it to become GFP positive and MAC1 positive? And so this concept of double negative to double positive, and this was at a time when the NIH was very interested in screening their deck, their 330,000 compounds, against all diseases. And so the same compound deck went into AML and Alzheimer's and whatever research. And we were assigned to the University of New Mexico. That was the only site that could do high-throughput flow cytometry at the time. And so that involved a lot of trips to Albuquerque. Albuquerque is very dry. The incubators need a lot of humidification, so we had some problems with the screen. But when it was all said and done, over the course of about 6 months and 20 screening days, they were able to go through 330,000 compounds. And what was really scary is, of course, just the pitfalls of a high-throughput screen. There are a ton of autofluorescent compounds. And then there's a ton of other things that just, of course, drop out. So we very quickly got from 333,000 to 2,500. That was the maximum we could rescreen. 75. Then, of course, you can't find some. And in the end, we had 12 active compounds, which were not autofluorescent and which seemed to have nice activity in both mouse and human cells. And here was our favorite compound. The chemists looked at the 12 compounds, and the one chemist on the phone said, well, these are compounds that I would date, but I wouldn't marry. I guess that's a chemical term, right? So this was someone he would date, but he wouldn't marry, because they were thinking like medicinal chemistry. And then they went through about 6 months of medicinal chemistry, and were able to make 2 subtle changes. The R enantiomer, which was active, the S enantiomer was not, and the small change to the chloride group. And this, actually worked pretty well. It was about a micromolar compound, and it worked in our screening system, and it worked in actually quite a few models of human AML cell lines. And it caused, just like we talked about, these are the differentiated cells, And now these are the chemically differentiated cells. They look the same. They're gaining all those nice markers. But of course, this was a phenotypic screen. So at the time, we had no idea what the protein target was. And so applied for grants, and the grant says, we'll come back when you have the target, and applied for more grants. There's like, well, you just have a compound. And so we got very fortunate because at the time, another postdoc in the lab said, well, just take a picture from the bacterial guys, right? Just make a resistant cell line and then work backwards and see what the protein target is. So this was very easy. It just took 6 months. You change the media every 4 days. It was a ridiculous idea, but it worked. And what was fascinating is it worked with 2 compounds, actually, and it worked in both mouse and human cells along very similar kinetics, which in retrospect was just fortunate. And in the end, we sequenced those cells, and there was only really a handful of genes that were upregulated. And what was remarkable, it's the same 8 genes in every cell line. And of course, as you might know from all these other talks, is that chromosomal amplification was then a likely mechanism of resistance. And when we went back, of course, it's the same 8 genes on the 16th chromosome of the human cells and on the 9th chromosome of the mouse. So it was a very fortuitous way to get back to the protein target. And then, of course, identify that this was dihydroorotate dehydrogenase. So then I vowed never to work on tumor metabolism. So now here we are, working on tumor metabolism. So DHODH is called the 4th step in de novo pyrimidine synthesis. So making uridine, which of course then makes cytidine and thymidine. So it's the 4th step. It's a mitochondrial, or the enzyme is not mitochondrial encoded, but it sits in the inner membrane of the mitochondria. And it does a very simple reaction. It's the only enzyme that converts dihydroorotate to orotate in the body. And so why would inhibiting this cause differentiation? Well, of course, it makes sense why inhibiting that was interesting in 1985, right? If you paralyze the body's ability to make uridine, the cells are going to die. So it makes sense why it's a good anti-metabolite or a cytolytic. But now in our system, it's causing differentiation. So first of all, you'd say, well, David, that's a pretty weak molecule. Is it really targeting your enzyme? So this is just a in vitro recombinant protein enzyme activity, and we get very nice, just a very nice curve enzyme inhibition. You can see here that the one enantiomer is completely dead. And then what's kind of a fun experiment is that your body can survive without dihydroorotate as long as you give the uridine downstream. And so there's 2 ways to UMP, either through DHODH or taking it in extracellularly. So we said, well, we can rescue the phenotype by just giving a bunch of uridine to the cells. And indeed, you can completely rescue the drug effect. And indeed, you can actually knock out DHODH as long as you keep them in uridine. But what was remarkable is this said that all of the differentiation effect was due to that uridine depletion, and we could completely rescue it. So then, of course, you go right to Google. You're like, oh my gosh, there must be tons of these out there. And indeed, there's 2 putatively FDA-approved DHODH inhibitors. And I'll say putatively because they're very, very weak. They're even weaker than our HIT. And they may or may not actually be DHODH inhibitors. But that's probably a different discussion. But then there's this molecule. Again, studied in almost 500 patients. Looked at as an immune suppressant after it was looked at as a cancer molecule. And it's a pretty good molecule, much more potent than the FDA-approved leflunomide. And actually, it's like a nanomolar inhibitor of DHODH. When we compare it to so again, this is the differentiation effect in our cells. Here is Brequinar, which is, of course, 10 times more potent than our lead hit from our screen and many times more potent than the FDA-approved leflunomide. So a good DHODH inhibitor. And actually what was nice is, of course, had very good in vivo properties, right? Now, it's been in humans, so we could easily use it in mice. So, of course, we never wanted just to find something that worked in vitro, and so we immediately went to try to get some leukemia models. And the first thing you'd say, well, does it cause the same differentiation effect in mouse leukemia that it did in vitro? And what was very nice to see is after just 2 doses of Brequinar, you get this nice accumulation of cell surface markers from the bottom left to the top right. So it does cause in vivo differentiation. It's actually remarkably effective, probably partly cytotoxic, partly differentiation. But this is not a typo. This is actually, these poor mice, untreated, have almost a complete replacement of their bone marrow with leukemia. And upon Brequinar treatment, we can really suppress that. The spleen weight normalizes. The peripheral blast count that Rich talked about, that goes away. And remarkably, and we didn't actually know what to do, so we treated with 12 doses and then stopped. And remarkably, you get a very nice prolongation of survival. Of course, we didn't cure the mice. And so you can see that, of course, they relapse after stopping treatment. This was our 1-HOXA9 model of mouse leukemia. So then you'd say, well, how does it compare to standard chemotherapy? Well, of course, mice are not quite patients, but we can give the same drugs that you and I would get, cytarabine and doxorubicin. Humans get 7 plus 3, mice get 5 plus 3, 1, 2, 3, 4, 5 days of cytarabine, 1, 2, 3 days of doxorubicin. Or we just give them Brequinar. The Brequinar is kind of a nice drug. It's got a long half-life. We only have to give it every 3 days. It's well tolerated. And first of all, does it cause in vivo differentiation? And I think this is a fun slide because even though the flow is kind of pretty, this is a really striking look. These are now leukemic cells which have been sorted because they're green fluorescent, though of course you can't see that here. So these are all leukemic cells in an untreated mouse and in a mouse treated with Brequinar. And the mice do better. So these poor mice die very quickly. It's a very aggressive model of acute myeloid leukemia. Induction chemotherapy gives you 10 days. The mice get very sick, and you get 10 days of survival. And this is actually very statistically significant, and we see this multiple times. And Brequinar, again, 12 doses, so 36 days of treatment, and we get this huge prolongation of survival, though we have not cured the mice. Now, one thing that I think everyone's interested in, and I don't want to get into that debate about leukemia stem cell, but let's call it a leukemia-initiating cell for now. And have we caused enough maturation, enough differentiation to get rid of that leukemia-initiating cell? And this is a concept which I think most people in this audience get, which is that you can have a tumor cell, but not all tumor cells in the tumor can cause leukemia, right? Some are bulk cells. And if you transplanted them into a new animal, not all of them would be able to cause that leukemia. But have we been able to shift this balance of immature cells to mature cells just enough so that they don't become leukemia initiating anymore? And so this experiment is kind of a fun one, which means you treat one group of mice, and then you don't worry about what they've got left, but you then sort the cells. You isolate the leukemia cells, make sure they're alive, and then you immediately put them into another cohort of mice which you don't treat. You just use as a readout for if you have leukemia cells. And then you treat, same thing, induction chemotherapy. This causes a 99% loss in the leukemia, but you sort out the remaining cells, put them into new mice. And Brequinar, sort out the remaining cells, put them into new mice. And what's remarkable is if you do this with one mouse, this was just vehicle treated versus Brequinar treated, put in 50,000 cells and 50,000 cells of each. Of course, you've realized you have depleted many of the leukemia-initiating cells. Turns out that the math does more than a 90% reduction, even though it's only a 20-day reduction. But what was really striking is this one. Because the induction chemotherapy, the same chemotherapy that you and I would get, causes no depletion in the leukemia-initiating cells. You get a huge depletion in the actual bulk of the leukemia, but what's left has the same leukemia-initiating potential. And Brequinar, for better or for worse, differentiates those cells just enough to deplete the leukemia-initiating cells. And this was only 4 doses. What's also striking for the aficionados in the group is phenotypically, induction chemotherapy causes the same reduction in stem cells. But this is a functional assay. This is just what they look like on the cell surface. So I've given up on trying to believe these cell surface markers. What do they actually do when you put them into a new mouse? So, of course, you'd say, well, it's too good to be true. Brequinars must be terribly toxic. And what's interesting is that, of course, if you inhibit uridine synthesis, everything dies. And suffice it to say, in the early days of using Brequinar, a lot of poor mice had a lot of bad side effects. But if you use appropriate dosing, again with this every 3-day dosing. We were able now to give it for 24 doses over a total of 72 days. The mice survive on treatment. We have yet to have one die on treatment. And they gain the normal weight. They have a slight reduction in hematocrit. So there's definitely some toxicity, but like kind of grade 1, 2 hematocrit. Slight reduction in white blood cell count. And slight reduction in platelet count. But again, they grow and they gain weight normally. So that's nice. Well tolerated for a prolonged treatment. And I think, again, if you think about the paradigm that we'd like to use, thinking again about acute promyelocytic leukemia, those patients get 6 months of retinoic acid and arsenic trioxide. They don't just get a hit and run. They get 6 months. We'd like to think about something similar to that. We've tried this in many models now. I've shown you, of course, these 2 models. We have compared it to PML. We've got 5 human and a bunch of other lymphomas. And again, just the pretty pictures, sort of common human leukemia models, subcutaneous, and 2 intravenous models. So it seems to be good. And of course, DHODH is in every cell, in every leukemia, in every normal cell, in everybody's body. So it's a bit of an unusual target. A huge team that then got involved, and with a lot of help from the Broad Institute, and then later on some help from the folks at Bayer Pharmaceuticals. And it took 6 years to eventually get from screen to target to Brequinar. And then, of course, you publish a paper, and then 2 weeks later, you realize you're not the only ones in the game. And a company in Singapore made the claim that they had 30 kilograms of compound on their shelves. We're not really sure what to do with it. And now a company in Germany, they've got a drug, and then a company in Vienna, they've got a drug that they're taking into uveitis models of autoimmunity. So, of course, just like everything, every good idea is not really a new idea. But people are now looking back at this pathway. Again, Brequinar sat on the shelf for 30 years. We're looking back at this pathway. So I guess the one thing, as I sort of wrap up, the one thing that I will say is that this is an unusual drug target. DHDOH is not mutated in cancer. It's actually very, very stable. So when you look at the 50,000 people whole exome sequencing, it's really not mutated in any one of us in the room. It's a very stable enzyme. Of course, it's a critical enzyme. It makes uridine in everybody's body. So that's a little unusual. Turns out it's not even overexpressed in cancer. Well, this is a tough one because sometimes cancer cells have more mitochondria, and so they might actually have more DHODH just by virtue of having more mitochondria. But it's not overexpressed at the RNA level. So if you look in the TCGA and compare it to the exact database of normal tissues, it's very consistent. I've now made up this word, metabolic therapeutic window, because it's not really somehow your normal cells, or a mouse's normal cells, can tolerate pyrimidine starvation better than leukemia cells can. So there must be some sort of therapeutic window, which is not the classic IC50 therapeutic window, but more of a metabolic therapeutic window. Leukemia cells have to be more dependent on this pathway. Now, does that mean that normal cells just don't worry, or more normal cells are able to salvage more from the extracellular matrix? I told you there's only 2 ways to get uridine into the cell, so that could be one hypothesis. We don't know. And then what I mean, I think when I'm being optimistic, I think, well, actually, this is going to be a hard target for a tumor to develop resistance to, because they need it. They can't just knock it out. Now, the pessimist me says, well, we developed resistance in the lab just by chromosomal amplification, right? So then maybe any tumor will just bump up chromosome 16 and overcome resistance. But it's not the sort of thing where you could have, to go back to Rich's talk, 99% of your cells FLT3 ITD and 1% not FLT3 ITD. DHODH is going to be in every cell in the body. So it's sort of tempting to think it might be harder to develop resistance depending on whether you're an optimist or a pessimist. So again, now we're looking very interestingly. Of course, you've got a lot of companies that are a little farther ahead. And Brequinar is now sat on the shelf way off patent. Good molecule made by DuPont many years ago, and actually studied at the NCI with folks down there many years ago before I got into this. And again, a huge group. I've just sort of put up the really key players here. My boss, David Scadden, just across the street at the Center for Regenerative Medicine. Shri, who's been at this colloquium before, he was the one with the idea for making a resistant cell line. A lot of people who helped with the animal models. Tim did the medicinal chemistry on that initial molecule, was very helpful. Steve actually made all the Brequinar, sort of a silly story, but Sigma, we used so much of the Sigma's Brequinar that they went on back order, and they were selling 100 milligrams for $300. I just complained to Steve in the hallway one day. Literally 48 hours later, he'd made 10 grams for $100. It was just embarrassing that and it was white. The Sigma stuff was yellow, so Steve's was so much more pure. Then Mark Haynes, who actually literally put 1,200 384 well plates onto the flow cytometry machines because they were not roboticized at the University of New Mexico. And then Bayer's been very helpful a little later in the game, and of course now have an interest in the molecule again, like those other companies. So thank you very much.
I hate to confess it, but I was one of the authors of a paper on Brequinar phase 1 in Memorial Sloan Kettering. Anyway,
this is perfect.
We never did try leukemia. The question is that, there's an inhibitor of the first 3 enzymes of pyrimidine biosynthesis, the CAD complex, PALA. Have you tried that?
So that's right. So and there's an inhibitor of the 6th step, pyrazofuran, which has also, strangely enough, been in patients. And all of those have the same effect. Interesting. So inhibiting at step 1, 2, or 3, all the same enzyme, step 4, or step 6. So it's something in that pathway. And actually, it's a great question because we thought it might be mitochondria specific, but it does not seem to be mitochondria specific. Yeah.
So I had a question. Maybe I didn't understand where you were treating the mice and then taking out the cells and then inoculating a second generation of mice. Why could it not be that Brequinar has a differentiating effect that is not one way, but that you put them into the next generation of mice and eventually those cells de-differentiate again and start growing, and then that's why you see a lag period, shall we say, and why it appears to be, rather than they've killed off the initiating cells.
So entirely possible. And we haven't done those kind of careful kinetics to ask, they differentiate? They don't actually seem to be differentiating and immediately dying, like a terminally differentiated cell. So I think that would totally be within the realm of possibilities. Yeah.
And then when you did it for a longer time, did you go into No,
now we've got to do that, right? So it turns out we didn't think we'd be able to treat for quite so long. We've now had mice on drug for up to 120 days. Really well tolerated, remarkably, and now we should do those studies. And actually, at the end of that time, there's very few cells left, so it's hard to do the same study, but I like it. Yeah.
David, maybe the audience would be interested in the issue of how do you get this actually into the clinic? And I know that you've gone through extended negotiations.
That's right.
Have you gotten the companies finally interested in putting it into people?
So come, of course, tomorrow morning, Roger Kitterman from Partners Innovation Fund is, I think, our first speaker. So Partners Innovation Fund has been very supportive and has promised some but not all of the money. And now we actually are in that process.
Do you have a patent for this?
Oh, so good point. So the use patent, which is a pretty weak patent, but the use patent of Brequinar and heme malignancies has now been filed with MGH Broad Bayer as 3 co-holders of the patent. And Vikram in the back room there is now our sort of manager and trying to get all the things done to, can we get drug made? And basically, as you can imagine, can you beat these other companies into the clinic and actually show some effect? But more learn about it, and I think as the MDs in the room, there's a lot of delays, and you think, gosh, you'd really like to see if there's some sort of beneficial effect.
There's one other thing that occurred to me, and that is that you could use uridine as a rescue compound, so you could actually increase the dose of Brequinar to something that might not be tolerated in the absence of rescue, but after 48 hours of high doses, you could come in with uridine and rescue normal cells.
Yeah, I love it. That was looked at in rats and mice when they were studied as an immune suppressive. So you could do exactly that with an intraperitoneal uridine, completely reverse the toxic effects of Brequinar. So actually, if you worried about overdosing an individual, you
Yeah,
could do it.
yeah.
So yeah,
And how is the drug handled? Is it excreted intact, or is it metabolized, or do we know?
Right. So I guess like we've also talked about, this is a highly, highly protein-bound drug. So it sticks around for a long time. You can achieve 500 micromolar total drug in plasma. So
Wow, that's a lot.
99% protein-bound, so probably
Yeah.
5 micromolar free drug. And then it's kind of, it's got decent properties. So it sticks around for a long time and then eventually excrete in the urine. Yeah.
Yeah. I know you plan to do pharmacokinetic studies, which
That's
I
right,
think will
with
be
one.
really important. The other option would be to try to make a compound which is not so highly protein bound, which wouldn't have that very long half-life.
Right, and actually it looks like 2 of the companies have much more lipophilic, non-acid compounds that are not protein-bound.
Yeah.
Yeah.
What are the chances this has some chromatin modifying effect?
Oh, that's right.
Just being a metabolic.
No, it's true. Actually, we're doing exactly that because you think a couple of the PET hypotheses is you're affecting other epigenetic enzymes. Uridine turns out to be a remarkable shuttle for other things. It's a post-translational. It carries glicnac, N-acetylglucosamine. It carries a polysaccharide synthesis. So all bets are off in terms of what it could do. So we're looking now at some of those epigenetic changes.
That MLO model, that's a fully epigenetic model.
Right.
And even the HL60, I mean, a lot of the cell lines, you just worry whether there would be like 2 effects. And you know, when you have a drug with more than one effect, you usually have a better drug.
That would be good.
Not to say that that's bad. It's just
Right.
It's good to look into chromatin effects.
And I think actually looking at other tumors now.
Would you just expand for a moment? Is there any, have you seen any differential effects on any of the subtypes of AML, or have you looked at that?
So we've got a dozen models so far, but it's tricky because, of course, many of them are cell line xenografts, a couple PDXs, and we haven't been able to figure out. It looks like AML, everything responds. We've now done these large commercial available panels, so these OncoTest and Pan labs. So we've got about 400 cell lines that have been profiled now, and there seems to at least be some differential sensitivity. So hopefully we're trying to do that analysis to ask, are there markers of sensitivity that we can figure out? But AML seems to be all comers, and then we'll see if there's anything in solid tumors.